Namaste, good afternoon. I am Dr. Manish Bharti. I am working as a senior consultant and interventional intensivist in the Department of Intensive Care Medicine at Sharda School of Medical Sciences and Research at Sharda University. Today on 16 June, I am taking this as an opportunity to share with you that we have been able to inaugurate international projects in collaboration with Germany, which is named as Acute Care Bronchoscopy Skills for the Intensivist by the Intensivist. Now, this concept is happening for the first time in this country. In this meeting, we had the mentors from Germany, from India, from the neighboring countries like Bangladesh, and we are going to expand very soon this project as far as the acute care bronchoscopy skills is considered. In order to supplement this acute bronchoscopy skills, we have Dr. Amit Vij with us. He's working as a chief pediatric intensivist in the Department of Pediatric Medicine at the Sharda Hospital. And we are planning not only to restrict ourselves to the adult intensive care, we are also going to expand into the pediatric bronchoscopy skills into the pediatric intensive care. And in order to mentor it, we have a chief mentor, Dr. Amit Vij, and I would like to know his views that what he has been able to gain in terms of his experience from today's workshop and what he can see as a vision for this pediatric bronchoscopy skills in the near future with us. Dr. Amit.
Thank you, Manish. Of course, as we saw today, the two cases you did, one helped us in diagnosis and the other one helped in getting the requirements of positive pressure significantly lower than what was given before bronchoscopy.
Right.
So the proof of the pudding is in eating.
Yeah.
We saw what benefit we did to both the patients.
Right.
Within a span of half an hour intervention, and it was done in controlled environment, posing no extra risks.
No threat to the patient care.
Yeah.
Yes, I agree with you.
So certainly it is significant. I mean, bronchoscopy has been there for a while.
Right.
Mostly it was in the hands of pulmonologists,
Right.
who wanted to keep it close to their chest. But with people getting trained in just critical care, DM programs in critical cares coming up, fellowships in India and abroad in critical care coming up, more and more of doctors like us are getting their hands onto this scope.
Right.
And as you rightly said in the morning, that it is an elaborated suctioning process where you can see also.
Right.
So not just suction the things out, but see for the defect.
Right.
And so it helps in both the ways, not just clearing out the airways.
Exactly.
Gives us a view of the airways, gives us what is causing what problem in the airways.
Right.
So certainly in adults, you have proven it to be beneficial in these two aspects. But in pediatrics, if you say we have the facets of the importance of bronchoscopy is wider. I had a patient recently whom we suspected bronchomalacia. Bronchomalacia is a dynamic problem to be diagnosed. You cannot have a CT scan, you cannot have any other sort of scan, and you can't look inside the lungs, especially the airways, to diagnose.
Right.
Initially, it was, let's say, extubation failure or something like that. When the things didn't match up, we used to think of these diagnoses. Today, we think of them initially and we can diagnose them by using a bronchoscope. You put a bronchoscope in a breathing patient, maybe ventilated on positive pressure or spontaneously breathing patient, and you can see the trachea or the main bronchus or the further division getting collapsed in inspiration.
So, I'm very happy and I'm very glad that the way the bronchoscopy is becoming versatile tool, not only for the adult intensive care, but also from the pediatric intensive care.
I always thought that pediatric critical care or pediatric pulmonology is the branch where bronchoscopy should be used the most.
Right.
Because we have congenital issues like, as I told you, malicias, airway malacia.
Right.
Second thing, tracheoesophageal fistulas.
Right.
Maybe a subglottic stenosis.
Right.
A web.
Right.
All these kind of things. Now, foreign bodies, a child, a toddler up to 3 years, start putting everything in mouth, has more chances to aspirate it into the lungs.
Right.
Adults do not. They are careful. So foreign body aspirations, these are the diagnoses which you can easily pick with a bronchoscope.
Thank you, Dr. Amit. You know, you actually stretched my thought process when it comes to the bronchoscopy. And I'm very happy to learn from you that unless and until you have a diagnosis, you don't know what you're going to treat.
Yeah.
So with the help of this vision guided suction, which is not only used for the purpose of therapeutic reason, but also to making a diagnosis. And once you have a diagnosis, certainly you can say that whether it's going to be treatable or it's not going to be treatable, you certainly have a better prognosis because you know where you're heading. And last but not the least, this is a part of your evidence-based practice.
I always teach my students that being a physician, the most important job is to diagnose.
Very nice.
Once you diagnose, you can search the literature for
Yes.
best of the treatments available and what is running around where. What can you do based on the resources you have?
Right, right.
But diagnosis, nobody gonna teach you or no, any kind of Google search, any kind of literature
I
search.
understand.
The art of diagnosis is the thing for a physician.
Yes.
And certainly bronchoscopy, as we just rightly discussed, is an important diagnostic tool also.
Yes.
Not just suctioning and clearing the airway, but for diagnosis, especially in pediatrics, as I listed these 3 common things, airway malacia, tracheoesophageal fistulas, webs, any obstruction, or the foreign body. So these are the 3 things which pediatricians see day in, day out.
Right, right. So thank you, Dr. Amit, and I would like to congratulate you for your extraordinary participation today.
Thank you.
You were a great help, you were a great member, you were a great coach, you were the great mentor as far as execution of this whole exercise was considered. And let me tell you, I had a discussion out there with our chief mentors, and very soon we are going to have Scopy in your ICU as well.
Yes, we should.
So thank you, Dr. Amit, for being
you.
there with us.
Thank you. Thank you,
Namaste.
Manish.
Thank you.